Thank you all so much for being here. I'm Sarah. I'm an acupuncture student and the president of the OCOM chapter of SAME, and delighted to be moderating our last panel here of the day. We have three really wonderful providers who have generously agreed to speak to all of us to discuss successful business models for working with low-income populations. Barbara Martin, who's a physician's assistant, Sonia Sosa, MD, and Brian Little, DO. And I'm going to have all of them just go down the line. We'll start with you, Barbara. You can introduce yourself, say your name, pronouns, the institution that you're affiliated with, and a little bit about the work that you do.
Hello.
Oh.
Hello.
Is it on?
I probably have to turn it on.
Okay.
Is that working? No? Oh, there
Yes.
we go. Okay. Hello. So my name is Barbara Martin. As she mentioned, I'm a PA. My full title is I'm the Senior Director of Primary Care. I work with Central City Concern, so a nonprofit in downtown, primarily in downtown Portland, but kind of further out as well. And Old Town Clinic is our primary care clinic. I see patients there, and I've been a primary care provider there for almost 14 years. And then I've been leading the operations of all of the primary care programs for the last 5 years or so. And I use she, her pronouns.
I'm Sonia Sosa, and I am a physician at OHSU Richmond Clinic, so that's a federally qualified health center in southeast Portland. She, her. I have been at OHSU off and on since 2007, and at Richmond Clinic that whole time. Also spend a little bit of time at Rosewood Clinic. And I run our integrative medicine program both at Richmond Clinic within the OHSU Family Medicine residency and the kind of elective experiences for the OHSU medical students as well. And do full spectrum primary care when I'm at Richmond, and including OB and deliveries up at OHSU.
My name is Brian Little. I'm the medical director over at Outside In. I have been there for about a year and a half. Prior to that, I was the chief of medicine down at the State Psychiatric Hospital in Salem since 2011. I'm supposed to spend 50% of my time doing direct clinical work. Right now, it's closer to 75%. I'm an internal medicine doc, and I do primary care at our main clinic site on Southwest 13th. And I also work 2 days a week on our outreach medical van down at the Clackamas Service Center, primarily treating the homeless individuals who are residing off the Springwater Corridor Trail.
Wonderful. Thank you all so much. Just to outline how this panel will work, I'm going to ask each panelist a series of questions, and there are little cards around the room, so if anyone has additional questions, we'd love to hear from the audience. Feel free to just write down your question and then raise your hand, and a member of SAME will come around and pick up the questions and bring them to me. So we will go ahead and get started. We first wanted to ask each of you, and we'll start with Barbara, if that's all right. Often treating low-income populations is seen as a financial challenge. How can we as practitioners facilitate a paradigm shift in how we view these patients as an asset to our practice?
Thanks. Well, some of these, these are complicated questions, but we're going to do our best to sort of share some insights, if you will. I guess I would say the first thing I thought of with this is really just kind of sinking into the mission of what you're doing and what you're trying to do. And I think really this is the purpose of why Old Town Clinic is here, why my clinic exists. What we're trying to do is to serve folks who need our services, or hopefully want our services. So really, we're there to serve folks who are low income or having other, lots of other reasons why they may be coming to us. I think really my personal opinion is I want to work for an agency that's a nonprofit. I don't want to work with any sort of for-profit healthcare. I feel like I don't think that's the right way to go in the world, and I don't want to be part of that. So that's sort of some of my personal feelings about that. I think we get good at trying to be creative. I think we try to be innovative. We find people to come and work with us who are very clever and are able to navigate things in amazing ways, and hopefully even remember how they did that, so the next time they can do that again. And I think really building on that strength and innovation is something that really keeps us going. And then, of course, being, I think we all work at federally qualified health centers, and I think that's something that this is part of the mission of being a FQHC, but that also really helps us financially in terms of being able to be sustainable and be able to provide the services for folks.
When I was thinking about this question and specifically like thinking about like that paradigm shift and what can we do to change the view, I think that I kind of changed things in my mind, and it's not that we need to like change the mind of everyone who's already in medicine or change the mind of how people look at the patients, but we need to bring people into medicine and into healthcare who this is their mission and this is their goal. And so I think that we need to start looking at that from early on at who we're drawing into these careers. These are things that we need to start doing in elementary school and in middle school and in high school, and really start changing the people that we're drawing into medicine and drawing in people who understand that this is where we need to be, and that this is the population, that this is how we're going to make the biggest difference in caring for our whole population. When we look at our numbers and we look at our outcomes, we don't look so great. So if you want to just look at it from that perspective, like how are we going to make a difference? We need to make a difference with everyone and not just thinking about the top 10%. And so that's where I was really starting to think about it, is like really getting to kids when they're young, and kids who are growing up in more disadvantaged populations, and growing up in diverse populations, and by attracting those young people into medicine, I think that's where we can really start making a paradigm shift. Because the people who are in this work are the people who are passionate about this work. And all of us, sitting up here, we've been working in FQHC settings because that's our passion. And I think when you're in it, then that's when you realize, that's when you see the rewards, and that's how you get the rewards, because you know how it feels to make a difference for people who really need that care. Yeah.
I really think that it's, for me, it was much more personal. In medical school, they had us do rotations at shelters for individuals who were houseless. And that really stuck with me a tremendous amount. And it really breaks down that fear of these people that you see on the street. And because when you aren't exposed to them and you don't have interactions with them, meaningful interactions with them on a one-on-one basis, it's very easy to have those walls, and it's very easy to not see them as people. And I can't imagine now working with another population aside from the significantly underserved population. I will tell you, my first 5 years after residency, I worked for our Department of Internal Medicine for our medical school, and they had us running kind of our own internal private practices, and I had two different offices. One was in a very wealthy town in New Jersey called Cherry Hill, and the other one was in Camden, New Jersey. I'm not sure if any of you are familiar with that city, but it's extremely poverty-stricken. And the dichotomy of the interactions that I had between the people who were in the affluent area versus the people who were in the really poverty-stricken city was my interactions were so much more fulfilling and rewarding to me with those individuals who actually were in Camden. They were so much more appreciative of anything that you could do for them and just meeting them where they're at and working with them. So I think the paradigm shift has to be that we all have to actually start getting exposed. And it's not just for healthcare workers. It's the way that Portland views its houseless and underserved. There's a huge wealth dichotomy here also in Portland, and it's amazing to see. And so I think that just getting everybody out to interacting with people, to start seeing them with people, is really where it needs to start. And then once you start seeing them as people, it really is, it's tremendous. It's really life-changing.
Thank you. Our next question, especially since all of you do work at federally qualified health centers, I'm wondering, are there success stories that you can share for securing a grant or other types of funding for implementing nutritional, behavioral health, or other integrative programs? or advice for navigating barriers with administration to fund integrative programs.
Okay. Well, gosh, at first, I mean, I think I can think of a ton of success stories and cool things and innovations and that kind of stuff. I think a big one that comes to mind is not exactly, I mean, basically the integration and being able to support doing a lot of different types of work within an environment, and that happens currently at Old Town Clinic, that we have integrated behavioral health, both mental health services as well as alcohol and drug treatment services, and as part of the primary care clinic, which is really amazing and kind of unheard of, and that's been amazing. And then getting some funding in order to support that. Looking forward, CCC is going to be, we're building a new building on 122nd and Burnside in the east side, and that's going to be called the Blackburn Center, and it has huge integration. All kinds of, it's going to have housing and behavioral health and substance use disorder treatment and employment services and kind of everything that Central City Concern does, we're going to be doing there. And that was a massive success story in being able to get a huge donation that we got from local, 4 local hospital systems as well as Care Oregon to fund, donated together unprecedentedly $21 million towards this project. And it's going to be opening in July. So that was like an amazing, clever, way to leverage some healthcare dollars that were in the healthcare system that weren't really coming to primary care or to housing or to these things, and being able to try to fund some of that stuff. I think on a sort of smaller level, but important, we partner with Oregon Food Bank to do a Cooking Matters class on site that's been really, really helpful. We have a program right now where we have got some grant money that we're able to support people getting eye exams and glasses for folks who don't qualify. Like a lot of insurances, a lot of Oregon Health Plan does not cover a routine eye exam or glasses. I mean, that's life-changing to be able to have a pair of glasses to be able to see. So we have a program that we're doing that. I could give a lot of other examples, but I think it's there's a lot out there, and there's a lot of opportunity and possibility.
So I was going to also say, I mean, definitely, I think probably all of us will be on a similar page of definitely like partnering with Care Oregon and utilizing them as a mechanism for pushing a lot of change forward. We also partner with the Oregon Food Bank and do Cooking Matters courses, which has been really awesome. And that just brought up for me, partnering with local community organizations has been really huge. Like, we don't have any, huge grants that are building a new building, but just like small things that are, that you partner with local organizations are a really good way to get things off the ground when you don't have a big grant to push something forward. So when you can partner with the Oregon Food Bank, or we were able to get a smaller grant through Care Oregon and then partner with local farms to support community-supported agriculture. So in the summers and for about 6 months, we can get families at our clinic food boxes, and they come and they get produce, and they get to learn what to do with the produce, and that's been really exciting and awesome. We have we've partnered with a yoga studio that's nearby to teach yoga at Richmond Clinic, and yoga that's really geared towards people of really various abilities, and so in making partnerships, that's how we've been able to offer a lot of services that otherwise our patients either aren't going to be able to go find or won't access. There's a lot of what you can bring to the clinic on site is going to be so much easier for a patient to access. There's so many reasons. It's more comfortable for them. They know how to get there. They're already there. And so we find that providing things on site has certainly been a really wonderful asset.
One of the things that I would caution you about if you are getting into this and looking at different funding streams is there are a tremendous amount of different opportunities and funding streams, and to make sure that you do not overextend your clinic. So that is one thing to definitely be concerned about. You may want to fix the entire world, and there may be a lot of avenues to do that, but you may not have the capacity to do that. 2 grants that we actually had a lot of success with that have really significantly improved the care we deliver in the clinic and the care we deliver to our patients is is one was called Wheelhouse, which was to join this group of other clinics and healthcare organizations in the area to go ahead and bring down the barriers for clinicians to go ahead and get their Suboxone waivers and develop really robust Suboxone programs for those individuals who are addicted to opiates. So we only had 2 practitioners prior to our participation with that who had their Suboxone waivers. Now every one of our practitioners has their Suboxone waivers. We've broken down the barriers for our staff to have Suboxone within primary care, and we've already tripled the amount of patients that we have enrolled in our Suboxone program. So that is really significant, and it's also because it's embedded in primary care. You have these individuals coming in for their Suboxone, but you can then also go ahead and address all of their other primary care needs. Another one that has been very significant is a grant through Care Oregon for helping to decrease emergency room utilization. There's a tremendous amount of people that either don't have the health literacy or just don't have the connections to think about getting any of their just basic health needs addressed through a clinic. Instead, they go to the emergency rooms. So Care Oregon provided a lot of funds for us to develop resources to reach out to individuals who really would benefit more from going ahead and getting into a clinic to get their primary care done than just showing up for sore throats to an emergency room. And this has also led to us partnering with different other organizations in the city to go ahead and help get people permanent housing as well. And a lot of times you will see some of these individuals, once you get them permanent housing, the emergency room utilization actually drops dramatically because now a lot of their social determinants of health are being addressed. So now they have housing security. Because they have housing security, they now have medication security because they don't have to worry about those medications being stolen. Their medication adherence is going to be much more significant as well. So there's a lot of opportunities that you can utilize with your own organizations to really make changes within the organization to really assist your clients.
Thank you. It's inspiring to hear that there are so many funding opportunities available and that they can have these ripple effects and lead to other opportunities for clients that you're working with. Brian, we'll start with you for this next question. What are the steps to accepting OHP as a practitioner, and how do you deal with gaps in coverage?
Sure. So essentially, hopefully if you're going to be joining a practice or something, that you'll have some credentialing specialists that can go ahead and submit your applications. To do that, we have that at Outside In. I'm sure that OHSU and also Central City have that as well. I don't have very much experience doing it as an independent practitioner, but you can submit the application to go ahead and get credentialed with the different OHP. One of the things that Outside In has struggled with was after the grandfather period ended with the Affordable Health Care Act. So you had individuals who were enrolled in the Oregon Health Plan for about 2 years. And we have at least 40 to 50% of our clients are houseless. So this means that they don't have an address, a lot of them don't have phone numbers, and so they've fallen off the rolls of Oregon Health Plan. I've addressed this actually with OHA to find out what they're doing because they've kind of turned to the clinics to make us go ahead and try to go ahead and re-enroll people. So we have enrollment specialists that try to go ahead and capture the people when they're coming into our clinic to help them get re-enrolled. But still, we have at least 35% of our clients do not have current health insurance. We treat everybody regardless of the ability to pay. So we also have an on-site pharmacy, and we go ahead and fill prescriptions for everybody regardless of the ability to pay. So we actually give out for free about 24,000 prescriptions per year out of our clinic. So Oregon Health Plan is fantastic, but you really need to go ahead and have a structure in place within your healthcare organizations to make sure that your most at-risk individuals get re-enrolled when they come in. Outside In initially did not have any enrollment specialists, and we were really struggling, so we had to make a organization-wide decision to actually invest in enrollment specialists to, yes, it helps our finances, but at the end of the day, it really helps to give those clients much more access to health care if they actually have the OHP.
I wish I had more specific information to add to this. I don't know that I have that much more. Again, being part of a university system, like, accepting OHP was kind of is just built in. to my clinic setting, not built into all of the clinic settings, but as we're at the FQHC for family medicine, it's something that we do. I would say our eligibility, yes, specialist is definitely a key person in our clinic because, again, in a similar place, I mean, we have people who come in who have lost OHP and they're able to help in real time, get them re-enrolled. Yeah, I think it's a similar thing. Like we'll see people regardless, and that's something that we go through all the time. I'll have a patient that's like, I'm going to lose OHP in 2 months, and one of my saddest times is when a patient comes in after like 2 years and like, I lost my insurance, and I just feel so bad that they didn't know that they could keep coming to us. So we see everyone. They can work with our pharmacy too if they aren't currently insured.
Yeah, I would say I don't have a ton to add either. I mean, that's something primarily we definitely reassure patients that we will still see them. So like certainly those times, the people are fearful about this and what's going to happen and what, and generally, we will still see you. We can do our best. It may change a couple of things we need to do, but we're going to figure it out. We're going to work together. We also have an in-house pharmacy that it's called a 340B pharmacy. So we're able to get, because of being a federally qualified health center, you can get medications to your pharmacy at a discounted rate, and then we're able to dispense medications. So for the folks who are insured, we can get a little bit more money for those. So that helps kind of fund the uninsured and folks who can't pay anything towards their prescriptions. So that's something. We have also participated in patient assistance programs from like pharmaceutical companies have programs where, filling out applications. It's complicated. It's, people have to bring in paperwork and stuff, but sometimes it works out. We used to do that quite a bit more before we really had our well-established pharmacy in-house, but that is still an option. But yeah, I think the main thing is having enrollment folks on site, trying to think ahead a little bit, trying to help people not freak out when, something's happening. And then sometimes when we know something's happening, having a plan around that. So like last year when family care went out of business, we had a lot of patients kind of like, oh my God, what's going to happen? And we were able to kind of we navigated with HealthShare because all the patients were coming over. Pretty much all of them went over to Care Oregon. We were able to track it. We were sharing lists. We're making sure that people aren't getting dropped off the rolls in that way. And so that was reassuring, I think, for our clients that we also had their back in that way. But yeah, I think it's part of the deal of enrolling at an FQHC.
Thank you. And to add on to that too, I know in the last panel, Pat Buckley had talked about some community health access workers, and I'm going to send out a list of resources to the email list of the event, because those are also people that I think assist with helping people sign up for insurance if they're not enrolled on site at a clinic. Our next question is, what resources and community partnerships exist for small business owners that might help treating these population groups that you know of? Yeah, we can. We can start with you,
This is
Barbara,
another hard
okay.
one, kind of. Okay, I'll take this one for the team. I guess I would say, small business owners. So I'm like, I don't know what that means exactly. But I think some of it's just, I guess I took this more as partnerships, like sort of what are the partnerships that we can build on and work with. And I know Pat Buckley, who was here before, was talking about some of our partnerships with TPI is a good example. So that's Transition Projects Incorporated, who runs a bunch of shelters around town, and partnering with them about trying to provide healthcare sometimes on site at the shelter or day center, and sometimes just coordinating care to be able to help them access Old Town Clinic, often, trying to get people engaged. I think other partnerships that are really helpful are things like the Coalition for Community Health Clinics is something that we are part of. That's a Portland organization that has both federally qualified health centers as well as community health centers represented in a group. We come together and meet every 2 months, I think, at this point, and kind of talking about what are common issues that are happening in other clinics. How can we all strategize about working better together or better with a payer or, options like that. I think Oregon Primary Care Association is also another really good one. That's the state of Oregon. All of the federally qualified health centers are members of the Oregon Primary Care Association, and they do things like learning collaboratives on a new metric that we all suddenly have to do, and we're like, what is that? And we can, sort of try to learn from each other and figure out ways to strategize to try to meet goals and that kind of stuff. So I don't know if this 100% is answering this question, but I just thought I'd take it to other partnerships.
That's helpful. Thank you. That's great.
Thanks. So that was a lot of good ones. I know, I'm trying to think of what other, I mentioned a lot of the partnerships that we have at Richmond specifically, and I think that those, since we're not the small business, that's where we're kind of using our small business, or we're using our relationship with small businesses to actually help build those small businesses. So if I kind of think about it from the other way around, like when we're talking about partnering with a yoga studio that comes to Richmond Clinic, the reciprocal relationship is that we're then sending other patients, some of whom actually are paying for their classes, to the same yoga studio. And so in that way, as if you're on the other side as a small business owner who owns the yoga studio, or if you're an acupuncturist in the community, I think developing partnerships with bigger organizations like FQHCs that we're representing can help you to not only be in there serving a population that you have a goal to serve, but then also can get other business from the faculty or the staff or other patients as well. So we have, I have some of my list of like private acupuncturists that I'll send patients to who may take OHP, but then I'm sending them some of my privately insured patients as well. And so I can see that as a way that we can kind of have a beneficial relationship for both parties.
Yeah, and our organizations are very similar on our FQHC clinic size. One of the things that we also do is we have a very robust volunteer program that we get a lot of volunteers from the community and from small businesses. Outside In has about 180 full-time permanent employees between our youth department and our clinic services, but we have about 350 volunteers at any point in time as well. So we do a lot of partnering for volunteer services.
Can I one more thing? Also, just thinking about that too, we also have a lot of volunteers, and also and working with in your neighborhood. So thinking about where you are and who are your neighbors, who are you working with? Because sometimes I think it can be challenging for other folks in the area to have an FQHC in their area, which may be bringing in more people who are in poverty or maybe having some other issues that may affect the neighborhood. And so I think really partnering with your neighbors, with your, so like Portland Business Alliance or something that we work with them, we, and really trying to partner with our, like the bagel shop down the street, like going there and they're like, hey, I went there recently and they were like, hey, by the way, at 3 o'clock, like we finish up and anybody from your agency is welcome to come in here and you can get the bagels that are going to be, otherwise given away. Like, how cool is that we can support each other in that way? So just kind of thinking about where you are.
Great, thank you. We have a question from an audience member. They're wondering who writes your grants. Do you hire someone to do this, or do physicians complete grants themselves?
We currently do not have a dedicated grant writer. The 2 grants that I had mentioned before, I had actually written. Grant writing sounds like it's a very, almost like this mountain you have to climb. It's actually, some of the grants are not too terrible to write, unless you're going after some of the federal dollars. Those grants are usually quite voluminous. So it just really depends on who currently at Outside In has the most amount of expertise to be able to write the grant. A lot of times it may be the entire management team is actually doing it as a project, and each one of us is taking our own piece of expertise to be able to do that.
Yeah, I would say similar. Yes, we have to work on our own grants. We don't have a specific grant writer to do that, but we do have a lot of support. So there's help from the management team at our clinic. My Department of Family Medicine has a team that goes through and makes sure everything is together, and we'll do the final kind of presentation of grants. So there is support, but yes, we certainly write our own grants.
Central City Concern as a whole does have a person who works on grants, so one individual, and but he focuses on a very wide array of things, so that's certainly not like he's going to come running to you to come and write your little grant, So I think that there's, we do have some support in that way, but we do have some opportunities to be able to write a smallish grant or something. I did one when I very first got there, and I think some of it is also about making sure that we're just aligned, you know what I mean? So that we're not having a whole bunch of different people writing different grants and doing different things, kind of like Ryan was getting to, like, be careful what you're biting off here. And some grants really come with a lot of stipulations and reporting requirements, so make sure that you kind of know what you're getting into. And being aligned. And then we certainly have a finance team and contracts team, and those folks really need to be involved in that, setting up the budget for this grant and how it's going to work and all that stuff. So on some level, yes, and it's also like super complicated, and at times it can feel really complicated and a little bit daunting, but that doesn't mean you can't do it.
Great, thank you. Sonia, we'll start with you for this next question. How can you motivate patients to remain vigilant with their health treatments to avoid further health complications? Remaining vigilant with medications to avoid further surgeries or procedures which end up with higher costs, for example?
I was looking for the question here, and it was not
Sorry,
there.
An audience question should have prefaced.
So my first and biggest response to that is you have to find what drives the patient, because it does not matter what might drive me to make those changes. It doesn't matter if I'm trying to save the system money. It doesn't matter if I'm trying to keep them out of the hospital. Like, it doesn't matter, just none of that matters what my goal is. The thing that's going to make any difference is figuring out what their goal is and what I can get them motivated to get behind. And so that's the joy of being a primary care provider, is that I can build these long-term relationships with patients, and I can say, let's think, what is it that's going to help you to make this shift? Maybe it's that you just had a grandbaby and you really want to be there for your grandbaby. Maybe it's that, there's so many different things, and I will only know that if I can get that from the patient specifically. So I think I spend a lot of time trying to just get to know my patients so that I can help them to help, to figure out what that hook's going to be. And then we work from there. And then we say, okay, so I can think of these 3 things we could work on in order to help you to meet that goal. What do you think you can try and work on for the next month? And then we'll come back and see how that works, and maybe we need to shift a little bit and try something else.
Yeah, if you are going to practice medicine with a lot of patriarchy, then this is not going to be the area to be working in. It's really about meeting the patients where they're at and really just trying to come up with a solution that they will be agreeable to. And a lot of times it's not going to be ideal. We said at a different panel before, it's not going to meet the standard of medicine. And a lot of times, it's borderline that you can actually start to see that this individual is going to be putting themselves more at risk, but you still need to try to keep working with them, because where we're working with these individuals, we are sort of the line of last defense. If there were not FQHCs that were working with this population, I'm not really sure who would really be trying to do this definitive care with them. So it is really harm reductionist, really trying to meet people where they're at. And it can be frustrating. I'm sure a lot of you are type A out there, being in the health-related sciences, but you have to let that frustration go. It's really about making those connections, trying to help them where they're at. You may, we down at Clackamas Service Center, there's a particular individual who needs to be coming into wound care, and we are right there on the medical van, and he is 30 feet away, and we have not seen him now in the medical van for a month and a half, and we keep trying to convince him to come in to get the wound care. He won't let us do it out on the street. It's really, but we keep trying nonetheless.
I'd say the only thing I have to add to that is just, I guess, working sort of at a baseline, assuming on some level that our clients have had some likely trauma associated with the medical system. And kind of that's a starting point, and kind of assuming that they may have some challenges with what I think is right or whatever. And so definitely not starting with the what I think is right statement. I also think there's also that balance on the other side that I always try to keep in mind as well, is that we also don't want to not have expectations that we could have better health outcomes or screenings or whatever. I've actually been, I'm sure we all have been very pleasantly surprised on occasion when someone's like, sure, no problem. And they take their fit kit home and they did it and they mail it in and they're like, boom, you did your colon cancer screening. That is awesome. Like, that is maybe not something that I thought was like totally going to happen, that we were going to have, over half our patients be appropriately screened for colon cancer. And that's where we are right now, which is amazing. So I think it's both. It's being able to meet folks where they are and also still having some, I don't know, hope is the right word, but like not expecting that you can't do it either.
Wonderful, thank you. Brian, we'll start with you for this next question and work our way left. This is another audience question. How can other clinics integrate practices to create a more accessible environment for low-income patients?
Yeah, so that's, tough, because one of the situations that you will deal with if you have a private practice and then you have low-income people or people who are houseless who just don't have access to regular hygiene, and they see these individuals coming into the waiting room, then your desk manager or your clinician is going to hear about it. And again, this is kind of what I was referring to earlier, that not just Portland, though, but just, this entire country has an issue with not viewing these individuals as people and really, getting to working with them and finding out who they are, because the stigma is there. And, I would be, not to say that there's anything wrong with Lake Oswego, but I can guarantee you that some of those clinician offices in there probably would not really tolerate some of our clients coming in, who haven't showered in 3 weeks. I mean, there's going to be people who are going to complain. And, so I think that if you're going to really try to deliver care to these people who are most at need, it's going to be an entire paradigm shift for your entire staff. And also for your other patients that are going to be waiting in your waiting rooms as well. So that's really kind of, I don't have much more to say about that. I mean, it's really just going to be, you have to be ready and willing to be able to deal with whatever's going to walk through your door and meet those individuals where they're at. One of the situations that we deal with at Outside In very frequently is that clients also have to act very aggressively on the streets to get their needs met. And so they come into our waiting room, aggressive. And, a lot of our staff are very skilled at de-escalation, and we have a very high tolerance for behaviors that would be acting out, because this is how those individuals get their needs met on a daily basis. And so if you have your staff in your clinic that are not prepared to either help to de-escalate or understand that these people are not coming at you, they are trying to actually help themselves, then you're going to have a problem with that. So really, it's before you take that leap into really trying to help these individuals, you have to be able to accept the whole person and their behaviors along with that, and also maybe their bad hygiene and a number of different things. And because if you don't, then those clients are going to feel that judgment, and it's not going to be an ideal situation for a therapeutic relationship between you and your clients. So that's just one of the things that, some of the things that you really have to consider with this.
I guess some other things to add to that are, just in thinking about how we can make sure that our care is accessible, is thinking about things like appointment, how you arrange your appointments. So do you allow patients to come late? Do you allow them, do you have a lot of same day access for appointments? How do people access your care is another thing to think about, because when you have to take 3 buses to get to the clinic, then a delay is not going to be unheard of at all. And so how can you work with patients to see them when they're able to get there, which is obviously challenging and can lead to a lot of disruption in your day, but something that we have to figure out. I'd say we have a very mixed waiting room at Richmond, because we do have a pretty wide demographic, and it is sometimes interesting. I think it's been that way for a long time, and so it's something that people are more accustomed to, and we have patients kind of a wide variety of incomes and socioeconomic status that are all sitting in our waiting room together, and definitely having a staff that is really, really trauma-informed and there and present and able to kind of to de-escalate or just to be present the moment kind of something comes up is really important. But our waiting room can be triggering for people. It can be kind of a chaotic place. I have one patient I'm thinking of, specifically that has a lot of anxiety and gets very anxious in our waiting room, and we're able to help her sometimes by like getting her roomed sooner if we can, and just knowing that she probably will have a heart rate that's like 30 beats higher than usual when we do room her because she's so triggered by her. And so just expecting some of those things, and working with them and trying to calm them when you can. I think having also all of the integrated services and having so many things available is another thing that's really important in dealing with an underserved population in general. So it's really hard to serve this population if you don't have a lot of these resources in place. And so if you don't have integrative behavioral health, we have a resource specialist now who, when I have someone who finally got a home and has no bed, I can go to her and be like, can you please help me get a bed? And she can, which is amazing. And so having people who can help do that sort of thing when you're trying to go from patient to patient is really important. Having a lot of resources available is one of the things that makes the care that we are able to provide possible.
I totally concur with all this stuff you guys are saying. You guys are super smart. I think just quickly to add, I think there's a lot of living in the gray, right? So there's a lot of times when it's not going to be like, this is our policy and these are our rules, and then therefore it's all going to work out that way, because it just doesn't usually. And so having a high tolerance for gray, and just kind of figuring out situations as they come up, thinking about, I can give a ton of examples of that. I think also trying to have some preparation for when things aren't necessarily going as well, without the expectation that things are going to go terrible, but having a bit of a plan. So at our clinic, we have some kind of response things that we do. So if there's a medical situation in the lobby, we have, it's called a rapid response team, and we have, somebody they can call overhead page, rapid response, and somebody will come and try to help and figure it out. We have a mental health kind of crisis response that's, if someone's presenting saying they're suicidal, we have we call it SCOD, Suicide Clinician of the Day, that's something that they can page, and one of our mental health people will come to that person or to the person who's on the phone with somebody who's saying they're suicidal, and being able to help kind of navigate that situation, as that's really scary for everybody involved, and kind of having a plan around that. And then we also have crisis response, which you guys heard from Chuck, who was on the previous panel, and he's still sitting right there, yay. And he does a lot of work with our clients in terms of there's a little crisis phone that we pass around, and Chuck has it a lot of the time. And our front desk or pharmacy or other people can call, and they're just like, hey, I don't know what's really happening here, but I could use some help. And he or a few other people are able to come down and try to kind of suss it out and try to keep things a little bit more calm, and try to help people navigate to, like you said, people are generally trying to get their needs met, and they're trying to interact in a way that maybe has generally worked, perhaps, or they're trying to get their needs met. And so I guess trying to approach it from that angle. I think that's all I have on that.
Great, thank you. If there are any more questions from the audience, please feel free to raise your hands. As you're talking about some of the needs that people of low income have, I'm wondering if you can elaborate a little bit more on specific needs, especially that individual providers should really be aware of, and if you see integrative services being able to address those needs in a unique way. And whenever you're ready, Sonia, we'll start with you, if that's all right.
I think a lot of that is things that we've, touched on, and that's just making, obviously, the first thing we need to do is make sure that, basic needs are met. So do you have food? Do you have shelter? Do you have, you know, I mean, I think like making sure that the basics are met and using all of the resources you have to make sure the basics are met is where you have to start, because people can't begin to approach other areas of their health if they don't have those needs met. But I think in some of the work that we do at Richmond Clinic, or that I do specifically, we have an integrative medicine consult clinic. So we actually bring NDs from NUNM, and we have our MDs and NDs from NUNM kind of work together to see patients and help them in addressing any wide variety of medical problems or mental health problems that they may want to discuss. But one of the things that we provide in that time, I think that's really valuable, is just time. We are able to see the patients for an hour when we first see them, and we hear more about them in that hour than probably, you know, it would take many visits to kind of get in depth as much as we do. And so we're really able to get a really, really good picture of what's going on with their life. Like, what is their day-to-day looking like? What are they, we do a really review what they're eating, what their resources are in a lot of depth. And then we are able to, in that time, spend a lot of time talking about just kind of a lot of the details that you don't have time to go into as a busy clinician, kind of going from patient to patient. So we can spend 5 minutes like teaching them how to do some relaxation breathing, and that's cheap and can be done at any point and can help to address a lot of the problems. So we talk about things like 4-7-8 breathing at 90% of the visits, and that's something that anyone can do at any time. And so giving our patients some resources that don't cost a lot of money, that don't take a lot of time, is really, really huge. We can sit down with them and say, okay, like how are you feeding yourself? What are you eating? And what are some really, really small changes that we can make that can make a big difference? We might have grand goals for how their diet's going to change, but let's just like start really small. And so I think just having that time to be able to do that has been something that's been really wonderful for us. And it's been a huge value to our patients and to the providers that are seeing them too. To have that time to sit with patients has been really great.
Don't tell my practitioners that you guys have an hour for your initial visit.
For 8 patients a month.
We expanded ours from 30 to 40 minutes for that reason, for our initial patient appointments. So I know that we had, it's been mentioned that the federally qualified health centers have something called integrated behavioral health, and I'm not sure if a lot of you are familiar with that. So we have essentially at Outside In, and I believe you probably have them at your organizations as well, is either MSWs or LCSWs that are available for warm handoffs at every single visit. So if we have somebody who's struggling with some mental health issues or with addiction issues or needs additional resources, we can actually go ahead and do a warm handoff to those individuals, and then those clinicians can actually spend even more time with the patient than what the provider actually has. In terms of trying to assist with the other social determinants of health, we are really harping a lot about houselessness, but really the houselessness drives so many of the other social determinants of health. Medication security is one of them. So our pharmacy will go ahead and do daily dispense of medications to individuals who are currently having their medications stolen. We have nurses available that if clients can't negotiate, checking their own blood sugars on a regular basis, or it keeps getting stolen, or it's too cold out, they can come in, and they don't need a visit to actually go ahead and get some of these things addressed as well. So it's, again, trying to provide a lot of extra resources for the clients for when they are ready to actually have their needs met.
And I guess I would just add to that, I think I feel so fortunate, and that we work in a clinic that has some incredible resources and integration, where we have, on site we have some mental health folks available for warm handoffs as well. We have health educators that are available for warm handoffs doing tobacco cessation, and SBIRT, which is a screening and brief intervention referral to treatment, so a screening around alcohol and drug use, and that's something where that's done as part of a routine visit, and then it's automatic that it then gets referred to a health educator who can kind of talk to them about the next step, so it doesn't become, oh my God, we just screened 6 more things, and now the medical provider's like, I'm not even getting to anything that we need, that we thought we were going to get to today because of all these new things, So trying to build some process around that. We also have, we have acupuncture on site. We have multiple acupuncturists who are incredible. And we have walk-in acupuncture available for any patient, any condition, 4 times a week, which is just phenomenal. That kind of blows my mind. It's actually an employee benefit too, so we can. Our employees can go and have some acupuncture as well. We have naturopathic physicians on staff as well, and we have an occupational therapist. We also have wellness groups, which has been really positive, and we kind of change what we're offering at different times. But things like art group, things like yoga. Actually, we have there was like a sock monkey making class, like. That is awesome. I was like, what? I want to go to that. There's a sober karaoke group, so there's some of it's around, and it sounds kind of silly almost, but it's also around providing a positive environment to be able to do something. And sometimes people can get out of their shell or try something different and hopefully in a way that feels safe. And I think that really promotes kind of that positive, healthy environment that we're trying to be part of.
Wonderful. Thank you. Our last question, we're a little short on time, but quickly, if you can just touch on this. So someone pointed out a great point that someone can be low income and also be non-English speaking or non-Spanish speaking, multicultural, a refugee, etc. Do you have special ways of dealing with these populations in the centers where you work?
Sure. So the second most common non-English language that we actually have is Mandarin in our clinic. So we actually have contracted with Mandarin interpreters to actually come to our clinic. I believe we all have the access to the telephone interpreters as well, which we go ahead and do. But ideally, especially with the Mandarin, having them available to come in, it is much more important than if they were a Spanish-speaking individual and doing a Spanish translator on the phone. There's just something culturally that really makes it much more meaningful to have those Mandarin interpreters available. In terms of people who are not documented, we have access to something called PANAU, which is, I believe we all have access to as well, which is a set of funds. Is it funded by the state or who's it funded by? I don't even know. Yeah. So we have an ability to go ahead and put in for different services for individuals who are undocumented that cannot go ahead and get health insurance.
I wish we had more in-person interpreters. We do have that as an option. So some of our our most complicated patients, we will be able to get an in-person interpreter for, but it's not all of them for sure. We have the phone interpreters. One of the places at OHSU that is utilized a lot is the Intercultural Psychiatric Center that has, I think there are like 150 languages that they're able to provide services in. And they have counselors, therapists in at least, I don't want to say this wrong, but in many, many different languages. So that's something that we utilize a lot for our patients. But something I wish I felt even stronger about what we were able to provide.
And I would say we do quite a bit of in-person interpretation. That is our general standard. If the appointment's made before the day of, that we try to get an in-person translator, which I think it's just so helpful in terms of, oh my gosh, a visit is much better in person. Something that we really want to strive more towards is having more bilingual, bicultural staff, not necessarily to do the translating, but to be part of the care team and to be part of the care for these clients. We do have folks who kind of a critical mass of people who speak Spanish, so that if a patient's calling, we're able to direct them to somebody who can have a direct phone conversation with them. But I do think that that's really something we are on the edge of and really want to do more of in staffing, both at our current site as well as other parts of our agency.
Great. Thank you all so much for sharing your experience with working with low-income populations and especially in the federally qualified health center setting. I think that's good exposure for all of us as integrative health students. So thank you, and can we hear a round of applause for our panelists? Thank you all so much.